Hello, everyone. Good afternoon, good morning, good evening, wherever you are joining us. My name is Zophia Edwards, and I'm an associate professor of sociology and Black studies at Providence College in Rhode Island. And it is my distinct pleasure today to be chairing, moderating this session on structural racism, health, and COVID-19. And as we are all very aware, COVID-19, this pandemic has exposed the deep fissures of racism, sexism, colonial logics that continue to fuel and structure capitalism and the profit motive. And so today, this panel was brought together to discuss, under the theme of SASE, how structural racism in particular intersects with health and health outcomes, and how we can deal with these pandemics. And so most appropriately, I think, specifically because our theme for this year's conference is after COVID with a question mark, right? And I want to be sure that we take note of the question mark in the title, right? Critical conjunctures and contingent pathways of contemporary capitalism. We have brought together three phenomenal experts who will be sharing with us their thoughts on this theme. And so before I do introductions, I will just say that we will first do the presentations. Each presenter has about 15 minutes each. Unfortunately, one of our panelists is unable to make it today, but that just means that we also have more time to go into more depth into the three presentations that we have today. And so they will present for about 15 minutes each, and then we will take questions at the end. Feel free to use the chat feature. And right now we have about 9 participants, so we can just do, Q&A very informally at the end. And I think those are all my announcements. I would also want to take a moment to especially thank Sigrid Quack, the president of SASE, who was really instrumental in helping to organize this panel here today with me as well. So thank you, Sigrid, and we see you on the call. And so first, I would like to introduce Dr. Brandi Summers, who is an assistant professor of geography and global metropolitan studies at the University of California, Berkeley. I will now turn it over to you.
Thank you so much, Sophia. And I'm really excited to be here. It's the morning for me, so I've been awake for a bit, but I'm feeling good that it's Friday. And also because we are a good and intimate group, I would like to encourage everyone to ask questions, or perhaps we can, as panelists, ask each other questions to, push the conversation a bit. I think given the topic and because, the question mark at the end of COVID, this is an ever evolving issue. It's a continuing crisis. And what it's done is expose so many other elements that have been unfinished. So as a geographer, there are, of course, spatial elements that I have constantly been thinking about, but more so not what is new about COVID, but what it's contributing to that's already existed. So today, so I've written a bit about specifically spatial containment and the ways that a longer history, specifically in the United States, that African Americans have experienced spatial containment due to a number of crises. But in particular, we're seeing this as it relates to health outcomes. There have been talks about, comorbidities and the impact on how long Black life can last, and then the quality of Black life as well. But more recently, as I've been thinking about the unhoused populations in the Bay Area in particular, ways that Oakland, where I'm originally from, and nearby, how the unhoused population in Oakland has soared significantly over the last 4 years, but primarily because 70% of that population is African American. It's important that we do think about the impact of structural racism on precarious life in various instances. But as it relates to COVID-19, I've been thinking more about the vaccines, actually, and just kind of the rollout in the US and the fervor around the rollout, choice, ideas that we should have a choice as to whether we vaccinate ourselves or our children or the elderly in order for us to be able to exist in public space. So, in particular, I've been thinking about that particular paradox of our excitement over the rollout of multiple vaccines and the presumptuousness of the widespread distribution actually fixing things that have occurred most recently. And so in the US, again, the rollout has led multiple state and federal leaders to determine that our public spaces are now safe and ready for full scale opening. And that's especially the case in California. But, as we know, the vaccine in many ways can protect us from the virus, but so many of us still are unsafe. The rollout was really another development in this evolving pandemic crisis that, like I mentioned earlier, further highlights and reinforces racial and systemic discrepancies that are specifically mapped along geographic lines. And so we've seen, over this year and a half, a spate of developments that have been occurring throughout the course of the pandemic, and to be mindful that we're still experiencing a pandemic and not that it's over. But again, throughout the course of the pandemic that have disproportionately affected African Americans within urban landscapes in particular. So first, thinking about the predominance of essential workers as Black and Latinx who remain on the front lines or who most often must risk their lives as gig workers and taking on other precarious forms of employment while having to travel to white enclaves to deliver food and other goods. So then the question is kind of what then is the vaccine for the concentration of Black and Latinx workers that are forced to work on the front line still, even though we're talking about cities opening up. Also, we've seen this expansion of poverty, unemployment, as I mentioned, homelessness, but specifically in relationship to eviction. So thinking about a vaccine, no two shots is going to deal with our upside down housing system that, again, we're continuing to experience. Then we're seeing the inadequate access to healthcare and testing sites. So it took a really long time for cities. There was this on Twitter, there was this account that kept showing a map of Chicago and showing the number of people who were dying in what regions and then those who were vaccinated. And it was completely upside down, where those who were dying less in those particular areas that were mostly white and affluent were getting vaccine shots at the highest rate. And it was the opposite for those areas, specifically in the South and Southwest areas of Chicago. They were receiving vaccines last. And that's still the case. The colors of the maps have shifted, but it was still significant that it's taken so long for there to be a particular rollout of the vaccines, and especially those most vulnerable areas. But again, thinking about those healthcare and testing sites, even the vaccine would be tempered, or at least the effect of the vaccine would be tempered by a lack of distribution channels and leadership in those areas. And then also thinking about the contrasting conditions with Black people being aggressively policed and Black communities still criminalized, while specifically, in some cases, white people walking around the street were getting masks handed out to them. And that was certainly the case in various cities in the United States. But after the vaccinations have had this more widespread distribution, we still need people to adhere to protocols. And so we're still having the effect of over-policing and this inconsistent approach to helping people adhere to the social distancing and mask wearing protocols that, since the Delta variant and then it's going to be the Gamma variant coming along and having this impact on our various societies. Then also, as I mentioned earlier, comorbidities in Black neighborhoods is determinant of COVID survival rates, not just infection. So we're seeing still this growth and existence of food and pharma deserts, especially in cities like I mentioned, Chicago, where there's a lack of adequate healthcare and safe and affordable housing, and that's undergirding the existence of the debilitating comorbidities. Also, I've been thinking more so about how government officials, and this was really happening at the end of 2020 for the most part, in the beginning of 2021, but we saw government officials and medical professionals using reductive and often patronizing tactics to publicly urge Black Americans to take the vaccine. So we saw Dr. Fauci encouraging Black Americans to take it because one of the leading scientists who developed it was Black. We saw the African American Surgeon General, Dr. Adams, urging LeBron James to convince Black people that the vaccine is safe, right? And so there was this distribution. What we need to recognize is distribution had more to do with access and not choice. And that's what it was introduced as, more focused on choice. And so, government officials specifically pandering to Black Americans and using Black celebrities and medical professionals to convince Black people to take the vaccine or that it's safe, again, ends up being reductive and incredibly patronizing. And so we did see how multiple factors still will determine whether communities get access or have access, and will continue to have that impact as time goes along. Historically, though, we can think about this long history of Black professionals being intimately involved, specifically in racist medical practices. So, one of the most notable was the Black public health nurse, Eunice Rivers Laurie, who was involved in the Tuskegee syphilis study, right? And so she served as a liaison between the US Public Health Service doctors and the men who were part of the study. And we know that the study was conducted based on the long held assumptions that racial difference determined health and disease outcomes. But specifically in the experiment, Black people were intentionally kept from receiving treatments. And so, the US Public Health Service selected Macon County, Alabama, intentionally because of its disproportionately high rates of syphilis. So you're seeing these ways that this longer history of racist medical practices, or at least using Black people as experimental guinea pigs in order to determine what can be safe for the larger population, still has this trace in the current moment now. And then the expectation that Black leadership or Black medical professionals will convince Black people to join in on these studies. So I had seen a report, it was on CNN, and they were talking about the rollout. Again, I keep focusing on Chicago. It's just the most incredible sight to think about all of these issues. But there was one Chicago resident, and she's like, if you came up with a vaccine in a year, why are we still sitting in a community where there's no grocery store with fresh fruits and vegetables? And so recognizing that the people in these communities know what's going on, and they're recognizing that even with this cure, that the social ills that still exists, especially as a result of racist practices, will remain and won't change their lives in significant ways. And so, I have focused on Washington, D.C., and I just saw these images of, Vice President Kamala Harris going and getting her shot. And it was in the hospital. It was the same hospital that in previous years was going to be shut down and was the only hospital on the Black side of town that they were going to shut down. So the irony that the Vice President was getting her shot in a hospital that without the actions of activists was going to be shut down was really profound to think about, and how we're kind of imagining these geographies of health, especially in Black communities. So, I'll kind of close, but thinking about, the geographies of the response to the pandemic and the distribution of the vaccines and the work of representation in our misunderstandings of both have been really taking over in terms of how I've been thinking about this and how we should think about it moving forward. We can still absolutely work towards building healthier communities, especially those that have been ravaged by COVID. but we also have to work towards ending racial injustice and economic inequality at the same time. One can't kind of dominate over the other, and certainly something that's been existing for quite some time. So ultimately, I really see this as the difference between vaccines and cures, right? So when we talk about the vaccine as a cure, that's different than understanding, again, these inequalities that continue to roam. And so we're acting as if we're being cured or healed from something, but really we're merely treating people and in the parts of the nation that we care to invest most in. And I think that's something we need to continue to think about as we have health crises that move us forward, but also the continuation of racial injustices, police brutality, all these elements that, again, that are co-constitutive of understanding the life chances of our most marginalized populations. So thank you.
Thank you so much, Dr. Summers, for that really fascinating presentation about the structures and policies and practices that are still embedded in the vaccine rollout and the role of Black professionals and celebrities in actually perpetuating those inequalities. I'm sure we'll have a lot of questions for you at the end. So now I would like to turn it over to Dr. Alexandre White, who goes by Sasha, who is an assistant professor of sociology at Johns Hopkins University and is also jointly affiliated with the Department of the History of Medicine. Sasha, I'll turn it over to you.
All right. You can all see my slides. Great. Thank you so much, and thank you, Dr. Summers, for your talk, because I think I hope to build on that, and I think the ways in which you framed these issues speak so much to kind of actually this unusual space that I find myself in now. I'm primarily a historical sociologist and a theorist with training in medical sociology, and also global in that respect. My research focuses on the history of international responses and regulations of epidemic outbreaks. So, but over the last year, I've also been turning a great deal of attention to the country, that I was born in, and the country in which I'm currently residing, which is the United States. So I'm focusing in this talk on that. But before I jump in, very quickly, I want to also highlight in this presentation that I'm giving that it's so much indicative of the fact that it's not necessarily so much that epidemics or pandemics produce novel phenomena, but rather expose in a far greater contrast the pre-existing inequities and inequalities that exist within our societies. And we've seen that so clearly, especially in the United States, but also around the world in the racial, what have been called racial disparities relating to morbidity and mortality in COVID. And this presentation is actually and I'm happy to talk about vaccine rollout aspects and the fact that we really can't be talking about vaccine hesitancy until we cover the access issue, which is actually part of the definition of vaccine hesitancy under the WHO, is that you can't talk about hesitancy unless people have access to it and are actively capable of turning it down without being encumbered by getting vaccinated. So I'm happy to talk about that and disparities, especially in the United States, around access. But in this presentation, I want to take us back really to the spring and summer of 2020. And this is I'm going to present the findings of a paper that I wrote alongside my co-authors, Lingsun Hao, Xiao Yu, and Roland Thorpe from Johns Hopkins on residential racial segregation and its effects on explicitly social distancing and capacities to social distance. And I want to really explicitly thank my three co-authors who, well, I certainly couldn't do this work on my own, and they were really the intellectual heft behind a lot of the modeling that I'll present in this. I'm not generally a quantitative sociologist, and I'm not generally a US-centered sociologist, so this has been a very different hat that I've been privileged enough to wear with these great scholars. So the objective of this study was really to examine whether residential segregation may be constraining capacities for social distancing and thus leaving, especially African Americans, Black populations, more exposed to contracting COVID-19. And while I say that that's the objective of the study, in large part, we we anticipated this answer to be true, and thus we were attempting to uncover the ways in which residential segregation may be affecting the capacities of people to to adequately care for themselves, fundamentally. As the pandemic continues to evolve, significant racial disparities in both confirmed deaths and cases have become sorely apparent. African Americans die from COVID-19 at a rate of roughly 2.5 times the rate of the white population. And though national hospitalization statistics are not uniformly reported by race, several studies demonstrate that African Americans are distinctly overrepresented among adults hospitalized for COVID-19. So we attempted to kind of explore these questions within a social determinants of health framework and analyze the mechanisms by which racial stratification, racial segregation, structural racism affects life chances under a pandemic. And in particular, we ask how the relationship between residential segregation and social distancing plays out along the course of periods of lockdown, quote unquote, lockdown to reopening under state-specific policy responses. So the spatial segregation of racial groups through residential segregation has been a central component, obviously, of the legacies of racism and ongoing systems of structural racism in the United States. And the laws enforcing the separation of racial groups have largely been repealed. Levels of racial segregation remain high, as do the negative effects of the persistent, separate, and unequal distribution of services and resources. And segregation has been shown to have a disproportionately negative impact on the health of Black Americans, affecting life expectancy, as well as the prevalence of certain infectious and chronic diseases. Research recently on influenza and the health disparities around the 2009 H1N1 epidemic in particular has shown that a variety of factors have led to the prevalence of H1N1 cases in non-white populations, including, as what might be unsurprising now, decreased capacity to effectively social distance as a result of the structural inequalities rooted in ongoing racial injustice. The overrepresentation of Black people as essential workers, as well as limited representation in occupations that can be conducted from home, suggests that these similar conditions obviously exist under the COVID-19 pandemic. So to analyze these particular questions, and I think that, in thinking about this question mark of after COVID question mark, especially in the United States, it's important to think about the context of this earlier work in relationship to these reopening strategies that we're going to be seeing really across the United States now and amping up really after July 4th. Because this research really gets to the question of what happens in periods of lockdown and subsequently reopening and how that exposes people to risk. But these data were taken from county level data across the country from March 8th to August 7th of 2020. We collected this through a COVID-19 data hub that we produced via the Hopkins Population Center of social demographic data relating to COVID-19. And we also drew from multiple sources from the Hopkins CCSE COVID-19 tracking system, which is the famous map that you've all become familiar with. The Census Bureau data, Centers for Disease Control and Prevention data, and the Bureau of Labor Statistics. And our analytic sample, well, really we split our analysis into two samples, an analytic sample and a hotspot sample. The analytic sample analyzed over 1,900 counties with over 283,097 county day observations to analyze fundamentally mobility in relationship to the Black-White Dissimilarity Index, which is a measurement of relative segregation within counties. And then we also had our hotspot sample, which was the top 100 counties with county level cumulative confirmed cases per 100,000 above. I believe it was above 15, and we looked at this from January 22nd to April 12th, and then from April 13th to July 24th. And our dependent variable in this was mobility ratio, and this was the maximum distance to a point from the initial point of day that it was collected, and M50, which we used we collected via Descartes Labs using mobile device locations in kilometers, capturing the distance of typical resident of a given county. The distance a typical resident of a given county moves in a day, and these are completely they're totally anonymous data. And some studies, such as Botter et al. 2020, have suggested producing mobility ratios based on the average number of total trips taken per day instead of total distance traveled. But we tested both approaches and found largely similar trends. So we look at the average total distance traveled in our analysis per day. To test our hypothesis that segregation constrains mobility under a stay-at-home order, but potentially increases mobility under a reopen order, we estimated an additive model and an interactive model with respect to the black-white dissimilarity index and policy variables for the sample of the 1,900 plus counties and 135 hotspot counties over 2 policy periods of kind of stay-at-home and reopening orders. And our key explanatory variable is the black-white dissimilarity index, which is a measure of the evenness within counties, black and white, within counties of black and white residents and how they're distributed across census tracts. And these data come from the Robert Wood Johnson Foundation. Policy responses to COVID-19 are the policy environment in which we examine the influence of residential racial segregation on mobility. And we use 2 state policy timing variables. 5 counties did not have the statewide stay-at-home order, including in Arkansas, Iowa, Nebraska, North Dakota, and South Dakota. And we translated the policy timing variables into 2 time-varying dummy variables. Stay-at-home takes a value of 1 for days under the stay-at-home order and 0 otherwise for reopen. Or reopen is 1 for days under the reopen order and 0 otherwise. Our analysis also includes 3 sets of control variables: geographic, demographic, and socioeconomic status. And the geographic covariates include metropolitan areas, and 3 dummy variables, including the Midwest, South, and West regions, with Northeast as the reference. And the demographic covariates focus on racial compositions, Black, Latinx, and Asian according to census categories, as well as population density. So I'm happy to talk more about the methods, but I'd rather show the results for the time being. So this figure depicts mobility ratio trends for the overall, for all the counties that we looked at, the 1,972 counties, and then I'll show you the hotspot counties in a moment. Both of these show that the 5 mobility ratio curves for the black-white dissimilarity indices declined sharply from March 8th to early April, and then the trends start to rise steadily to a near baseline level around July 3rd, and then level off. Now there are 2 noticeable differences between the 2 subfigures, which I'll show once I show the second one. But first, these 5 curves, as you can see, cluster closely in this one, and they diverge a bit in the second one. But what's important to note here is that this kind of magenta line, and I apologize if anyone has color sight issues, I'm happy to explain this further. But this lowest line here is a line representing the highest level of segregation according to black-white dissimilarity index. And what you see is that the slope of this line actually increases much more significantly over the period from lockdown towards reopening, such the mobility increases and actually overtakes all others really by the time you get to July 6th and the rise of reopening, which suggested in our analysis that the actual capacity to reduce mobility and thus and thinking about mobility as a proxy fundamentally for social distancing was greater constrained in more segregated counties. In the mobility ratio trend for the hotspot counties, what we see is that actually in the curve for the highest black-white dissimilarity index, while it crossed all 4 in the first one, in the second one we see that the relationship between mobility, movement, and segregation might be less significant in the hotspot counties, or there's less of a relationship. However, the magenta line once again continues to increase at a greater velocity than the others. And together, these patterns are consistent with our hypothesis that residential racial segregation obviously constrains social mobility, when the whole population is locked down, but increases the need for moving fundamentally under reopening orders. This is a snapshot of 9 hotspot counties reflecting both current and historical hotspots and visualizing their profiles of mobility ratio over the COVID-19 course demarcated by stay-at-home and reopening. So that's what these vertical lines are. Those are the different policy situations. And what we see here broadly as a descriptor is that we see a similar increased slope of the line in some of the more segregated counties, namely, as you see, Cook County, Illinois, or Chicago, Illinois has quite an aggressive slope, as does Wayne, Michigan, as does Milwaukee, Wisconsin, which we've seen as somewhat slightly more depressed in Los Angeles, California, and New York City. Two of the largest cities involved in this, but nonetheless, we see in the hotspots this level of this relationship between mobility and segregation seems to be consistent. So I'm actually going to skip to the discussion here as I'm running out of time, so that we can, and I'm happy to answer more in the Q&A. But results or research, especially on responses to COVID-19 from China and recent studies from the United States, demonstrate that reduced mobility has a significant effect on rates of COVID-19 incidence. And racial segregation, the result of discriminatory Jim Crow laws and redlining policies that prohibited the movement of Black populations into certain residential areas, has been shown to be a persistent fundamental cause of health inequalities and illness. And our research demonstrates that segregation also has a clear effect on rates of exposure to, and ultimately probably the incidence of cases of COVID-19. COVID-19 studies that have explored the racial and ethnic disparities in the pandemic, or racial and ethnic disparities in COVID-19 related deaths, suggest without a shadow of a doubt that minorities often face a higher exposure to disease due to longer durations of commute via public transport, as well as demonstrated limitations to working from home, as well as increased exposure possibly to contagion by working in the service industry or in the medical communities, where especially minoritized populations in the United States are overrepresented. So this deficit in home-based employment opportunities, as well as an overrepresentation of Black populations in essential work fields, as well as hospitality and service, may explain why during and after the relaxation of COVID-19 restrictions and employment in these fields returned, we witnessed an elevated mobility increase in segregated counties, as longer commutes from segregated areas were required to perform work outside of segregated living areas. And I think this all fits very clearly into Dr. Summers' analysis, but perhaps we can show you through this presentation a little bit more granularity here. So this analysis reflects, fundamentally a demonstrated need, obviously, to consider the legacies and complex influence of racism on COVID-19 in the United States, and that further interventions such as the reintroduction of lockdown orders, which we may see under this current Delta variant, and the relaxation or the provision of financial support for those under such policies should respond to the disparate effects of policy and the pandemic itself on different communities around the country. And moreover, persistent racial inequalities, especially in housing and residential segregation, suggest that one-size-fit-all interventions, such as lockdown stay-at-home orders, or one-size-fit-all interventions in terms of vaccine access and provision, may exhibit varying effects and have exhibited very clearly varying effects based on the intensities of structural racism. So I just want to end by saying that, while this focused very much on what we might call, the peak aspects of the pandemic and the controls around it, as we move into a period in which we think about, quote unquote, going back to normal, we have to recognize that the economic and political dynamics of who's working where, who make up the vanguard of essential workers, of medical workers, and those in the service and hospitality industry, as well as the disparities in vaccine coverage, could produce a very serious and severe, and once again, deeply disparate level of COVID cases and mortality, especially in minoritized communities. So thanks very much. I really appreciate it. I look forward to the discussion.
Thank you so much, Dr. White, for that really rich presentation with rich data on how we can think about how structural racism in terms of residential segregation and how deeply historical that is continues to have these manifestations today. And so thank you so much for that. Our last presenter for today is Dr. Jenny Douglas. And Dr. Douglas is a senior lecturer in health promotion and in the Faculty of Wellbeing, Education, and Language Studies at the Open University. I will turn it over now to Dr. Douglas.
Hello, everybody. Thank you very much for inviting me. I will now try and share my screen. This is where my heart sinks. Okay, can you all see my screen?
Yes, we can all see it. It's clear.
Okay. Okay, so I'm going to talk a little bit about structural racism and the state of Black people's health and well-being here in the UK. And, you know, we might ask the question, why do we need to focus on Black people's health and well-being? Well, here in the UK, Black people's health has actually been ignored for a very long time. We've been invisibilized in health studies, and we only have very little data on health issues that affect Black people. The positive thing about COVID, although there's not many positive things, is that COVID has shone a light on existing inequalities, and we are now starting to get data on Black people. Focus very much on COVID, but it kind of demonstrates that that we need to be collecting data much more. So generally speaking, we have very limited data that explore the intersections of gender, race, ethnicity, and social class here in the UK. And when we talk about structural racism affects every aspect of the lives of Black people in the UK. It affects education, both primary, secondary, and tertiary education. We're seeing very much in relation to university education that Black and minority ethnic students are less likely to get good qualifications, what we have started to call the awarding gap. We have seen it in relation to employment, that Black people are have to take particular areas of employment, which often is unskilled, often very precarious, often where they're exposed to all kinds of pollutants. And if we look particularly in relation to COVID, that it's been Black people who have been very much at the front line in terms of health and social care workers, and in terms of people working on transport, people delivering food. So it's those, you know, so it's Black people who've been very much in that front line of employment that have been exposed to COVID. If we look at housing, although we don't have the same kind of historical legislation in relation to housing here in the UK as you may have in the US, and the majority of, I just need to put it into context, the majority of Black and minority ethnic people actually migrated to the UK in the 1950s, post-1950s, although there had been centuries of Black people here before that. That was because, and particularly migrated from the Caribbean and also from the Indian subcontinent. People who migrated from the Caribbean were able to do so because of the 1948 British Nationality Act, so that people from the Caribbean, from Jamaica, Barbados, Trinidad, were British citizens. And many of you will have heard about the awful Windrush debacle. And what happened is that those people who came, who were called the Windrush generation, who came post 1948, the first ship that sailed was called the Windrush, and that came in July 1948. Those people that came, as I say, were British citizens. And what happened was that there was another Nationality Act in the 70s, which required people to apply for nationality. Now, most people didn't feel the necessity to apply for nationality, British nationality, because they were already British nationals. And this is where the whole Windrush debacle and betrayal actually occurred, so that many people suddenly found themselves without citizenship. And that actually affected their access to employment, their access to housing, their access to healthcare. And many of you will be aware that those people, many of those people actually died without getting their citizenship. And this is still ongoing. These issues are still. So that is the context in which I'm talking about Black people here in the UK. And so in relation to housing, although there wasn't clear legislation, because of the structural racism that existed in relation to employment, Black people found themselves having to purchase housing or to get state housing in those areas that were most deprived. And you will also have heard of the awful situation of the Grenfell Tower. And the majority of people living in Grenfell Tower were people from Black and minority ethnic communities. And that again, that illuminates the way in which Black and brown people here in the UK are perceived. So many Black people find themselves in geographical locations that are in socially deprived areas. And again, this is particularly important and particularly relevant in relation to COVID, because you might be in an area where there is dense housing, poor access to facilities. And the access to health and social care for Black and minority ethnic people is also contextualized by the experience of racism. I'll come on later to talk about Black women and maternity care, but here in the UK, Black women are 5 times more likely than white women to die in pregnancy and childbirth. And that has to be because of the structural racism that exists in maternity services. So what I'm trying to demonstrate is that structural racism not only affects every aspect of the lives of Black people, but it affects health and well-being throughout the life course. And, you know, as I say, I'm not able to show you a lot of data because there are limitations to some of the kind of research that we have on health inequalities. The research on health inequalities has not considered looking at race, gender, and ethnicity. So we have a long tradition of research that looks at poverty and social class and material circumstances, but that does not look at the intersection with ethnicity or gender. And then we get research that is focused on ethnicity or gender and class, but that doesn't consider the intersections of gender and race. Then we have some research on ethnicity and health, and that must be, which we must undertake, and we must look at the range of intersections, but that area is just developing now. And we need to develop appropriate methodologies which enable more meaningful and relevant research to highlight issues that may be of concern, for example, maternal mortality. If you look at maternal mortality, you can generally, you can see that it is improving. But if you start to look at it in relation to the experiences of Black women and Asian women, you can see that Black and Asian women are actually being, having disproportionate poor experiences of maternal health. I'm just going to run through a few issues very, very quickly. In some of the, and I'm focusing particularly on African Caribbean health concerns, that African Caribbean people are 5 times more likely than average to have high blood pressure and twice as likely to die of stroke under the age of 65. So for these people, the impact of COVID is going to be much, much greater because of the existing illnesses, underlying illnesses. Again, although women, African Caribbean women, experience a greater prevalence of hypertension than men, they are actually less likely to receive treatment. So we can start to see, there are differences in relation to gender. If we look at mental ill health, there's been a focus on severe mental health conditions like schizophrenia. And African Caribbean people, and mainly men, are between 3 and 6 times more likely to be diagnosed. Now, when I say diagnosed, that doesn't mean to say actually that they have schizophrenia, but the assumptions that health professionals have and the notion of black men being big, bad and black means that they are more likely to be diagnosed. We have very little research on African Caribbean women and mental health, but we're starting to see research on anxiety and depression. And of course, the stresses of everyday living and the experience of living in a racist society will take its toll on African Caribbean women. Perinatal depression, again, we've just started to see research here. But even though African Caribbean women are at higher risk of perinatal depression, they're less likely to be diagnosed. And, we have to ask ourselves the question, why? Why is it that Black women are actually being ignored? In relation to breast cancer, it's the same, that Black women are 21 years younger than white women when they are diagnosed with breast cancer, and they're twice as likely to die of their disease. So I really just wanted to focus on some of the underlying conditions that Black people experience. In relation to organ donation, we know that Black people are more likely to have hypertension and diabetes, and they're 3 times more likely to develop kidney failure, yet organ donation rates are much, much lower. I've already mentioned Black women and maternal mortality, that Black women are 4 to 5 times more likely, and Asian women twice as likely to die as a result of complications in pregnancy and childbirth. And again, we need urgent research. The same is true of stillbirths, that Black women are 1.5 to 2 times more likely to have a stillbirth. And underneath the kind of tip of the iceberg in terms of maternal mortality, we know there is a huge amount of maternal morbidity, and that is linked inextricably to Black women's socioeconomic position, their work experience, where they live, and their everyday experiences of racism and systemic racism. So COVID has shone a light on the existing long-standing health inequities. And we can't think about COVID without thinking about Black Lives Matter. So here in the UK, Black and minority ethnic communities make up 14% of the population, but they made up 34% of the critically ill COVID sufferers. And Black and minority ethnic people are twice as likely to die from COVID than their white counterparts. And the majority of doctors, both GPs and hospital doctors who died, were from a Black and minority ethnic background. So here we do now have the start of some statistics on Black and minority ethnic people and health. So long-standing inequalities are actually being exacerbated by COVID because of the increased risk of exposure to and acquisition of COVID-19. That's to do with occupation, population density, the use of public transport, household composition, and housing conditions. The difficulty that people who may be told to isolate have in relation to isolating. I've already said high proportion of Black people are key workers, and they're in occupations that place them at risk by increasing the likelihood of social contact and increasing the risk of being exposed to those who are already infected with COVID-19. The structural racism that exists within organisations and within and workplace bullying, racism and discrimination, and this is both within the health sector and within social care, means that it's very difficult for Black people to actually raise concerns about the risk to their health. And we've seen 2 deaths of Black women. One woman who worked for London Transport at Victoria Station, and she had underlying health conditions and had told her managers that she did not want to work on the front line, that she was, well, when I say encouraged, she didn't have any choice about the matter. She had to go to work, you know, for her own kind of economic reasons. And she was actually spat at by somebody who said they had COVID, a white man, and she died 2 weeks later. And there has still not been an inquest into her death, but her death was clearly due to occupational exposure to COVID. And another Black woman died who was a nurse at a hospital, who was pregnant. And although she had left work to start her maternity leave, I think about 2 weeks after she left work, she was admitted to hospital with suspected COVID. Strangely enough, they sent her home, even though they suspected that she had COVID, but because she didn't need oxygen, she was sent home, and she was then admitted the day after, and it was confirmed that she had COVID. She had an emergency cesarean, her daughter lived, and she died. So, you know, so there are 2 very clear cases of occupational exposure to COVID, although the inquest in the nurse's case said that she may not have been occupationally exposed to COVID because she'd actually left work 2 weeks before. So she may have acquired COVID from somewhere else. So, you know, the kind of explanations of the impact of COVID on Black communities has been quite complex, but we need to be able to look at a kind of intersectional complexity. There have been various explanations, from biological explanations in relation to vitamin D deficiency, but a range of factors, you know, relating to social and economic inequalities, racism, occupational risk, are also being considered in relation to structural racism. I don't know how much time I've got there. I'm going to wrap up really just by saying that race, we know race isn't biological. We know that race is a social construct, but the effects of racism have biological consequences, and that race is embodied in poor health. And these daily microaggressions, both the sort of systemic racism, but also the day-to-day microaggressions, lead to health inequalities. I'll just conclude really by saying how important it is that now that we have started to focus on Black communities and health in relation to COVID, that here in the UK, we start to build appropriate research projects and research methodologies which consider the kind of intersections of race, gender, class on the health of Black communities. I fear that I don't think we will ever get over COVID, but once there isn't so much of an emphasis on COVID, that we may go back to not looking at the health experiences of Black communities. So thank you very much.
Thank you so much for that really rich presentation on the importance of examining these inequalities and the lack of data, that the problems around the lack of data and the lack of research. And I think this will provide for a really good discussion, because we are talking not just about Black communities in the US, but Black communities around the world, across the diaspora. And so I will now open it up for questions. It's just a few of us. So I suppose if you have a question, you can just raise your hand and unmute yourself. And Sigrid, I see your hand up first. So there you go.
Yeah, thank you. Thank you very much for the presentation. It's very intriguing and rich and also sad data, but we know part of that. So, but I mean, you made it brought it very much to the foreground. So I have an uninformed and curious question about the discussion on access to vaccines in the United States, and maybe it extends also to the UK. I mean, I fully share your view that vaccine coverage will not solve the problems, the underlying problems, which are a combination of social, economic, and health inequalities that are kind of, you know, in structures and institutions, but also in thinking about, you know, Black and white people, and you have brought that out very clearly. I was more interested in really understanding what beyond that is really the problem of access at the moment. I mean, because as I understand in the US, there is an abundance of vaccines compared to what we experience here in Europe. I mean, UK is also different, but we are still queuing up in many European countries. I understood that in the beginning of the vaccination campaign, it was very much also an entrepreneurial skill that you needed in the US to have the connections and to get the access to it. But the last kind of accounts I have heard that people are throwing basically the vaccines at you wherever you go. I mean, I'm exaggerating a little bit, but I mean, so I just wanted to understand what are the kind of channels, of mechanisms, of everyday practices and processes that make the difference here, because I think that would be very interesting to know. And maybe my question to Jenny is whether we have similar phenomena in the UK for Black and ethnic minorities too. I mean, here in Germany, one case I know is that sometimes it is linked to residential areas, you know, because also migrants live, of course, residentially segregated in Germany, not to the same extent as it is in American cities, you know, where you cross one street and it changes immediately. And that there have been problems there, which have been addressed by basically doing very specific open vaccination campaigns in the places, which were, I mean, surprisingly well received after there had been talk about them being more hesitant to be vaccinated, which comes to the point, is it hesitation or is it availability and access, right? So I did also this kind of segregation, residential issues and availability of GPs and this, or are there other things at play here? Thank you.
So I'll go and just speak briefly about it. It has so much to do with infrastructure and whether there are communities that, so when I mentioned Chicago, where pharmacies were giving out doses of the vaccine. So the presumption, of course, is that you have a pharmacy in your community. And so with the exception of the Johnson & Johnson vaccine, you need 2 doses. So to have the transportation to get to the pharmacy in order to get your first and second dose, while having a job and having to kind of maintain the rest of your life in certain ways. So in a lot of cases, there were wasted doses in some communities where they were breaking it down based on the population numbers, but not again in terms of access, whether they could actually get to a site. And so I know, like, just in terms of the media, both national and international, there was this kind of talk about how plentiful the vaccines were. And if they weren't being used, it was because people weren't choosing to have them. But honestly, there weren't sites set up in enough areas. The presumption was if it was an unsafe location, then they wouldn't want to necessarily jeopardize the again, the safety of the workers who were distributing the vaccine, thinking again about those populations that don't have homes or who are moving from place to place. And so to be able to get the first and then the second dose. So infrastructurally, in the more wealthy areas and wealthy cities, it was a lot easier to make sure people had multiple doses, or they set up, like in Oakland, there was this huge site, and this is where I went at the Oakland Coliseum, but they shut it down actually really early. And so it was really accessible, especially for East Oaklanders, to come over, deep East Oakland, where it's mostly Black and Latinx. But then when they shut it down, people have to find another location. So ultimately it's infrastructure, but yes, it's definitely spread out more than it had at the beginning. But the way I think a lot of states were imagining the rollout, they weren't necessarily accounting for these various pockets, these deserts to exist.
If I could jump in and add to that as well, we have a lot of physical vaccine in the United States for sure. But if you look at, for instance, so I'm actually, after this call, I'm jumping onto a different call about vaccine equity and access, and a report that I'm working on with Hopkins. But if you look at Alabama, for instance, where I'm not going to put up a map, but like southern Alabama, for instance, is known, there's like kind of a line across southern Alabama, which is known as the Black Belt, which historically is the area where a large number of enslaved populations lived, worked on plantations, and subsequently became sharecroppers and agricultural workers, and now still reside in that area, which kind of bands across the south of the state. There are at times only one, perhaps 2 or 3 vaccination sites per county, and these counties are hundreds of square miles in size, which means that in order to get access to a vaccine, you have to drive to, you find some sort of transportation, get to what is usually a Walmart, take the time off work. You're talking about multiple hours, to get to places that are not accessible by public transport. And these are the sort of things that we're seeing in the regions that are still at the highest levels of disparities in terms of vaccine uptake. So that's where you find a problem. And I think the last thing I'll kind of say on this is the other issue is that there's the very significant problem of, over the last 60 years or so, global health funding per person has just dropped off in the United States completely. So, in conjunction with the histories and legacies and ongoing forces of structural racism that affect access and things, there's also much less access and relationship between any sort of public health authority that compounds, the already existing issues of just interpersonal health access. So these are the kind of things where we're seeing, the US as a whole has rather strong vaccination rates. Once you start to look regionally, we have very, very serious problems. And, especially as the Delta variant spreads, we're going to continue to see, significant, I fear significant surges in those areas of cases and death.
Hi. In the UK, I mean, it has been quite varied. I think that initially there was a lot of, I don't really know whether to call it vaccine hesitancy, but people were very concerned about the vaccine. And that wasn't just in relation to Black and brown communities, it was also in relation to white communities. I think that what has happened, and I heard what you said, Dr. Summers, about Black professionals and celebrities being involved, and that is what has happened in the UK. Black celebrities and Black professionals have got involved in, producing webinars, information on vaccines. There's been a lot of work with community organisations, and so there has been a greater uptake now with Black and brown communities, and also working in local communities with different religious organizations. So I think that there is, a lot of access to the vaccines. And I think as well as the kind of political and historical concerns that people had about vaccines, you know, in relation to knowing how, you know, Black and brown people had been used for medical experimentation. There was also a lot of myths about the vaccines. And I think that a lot of the community groups had to do quite a lot to dispel those myths. So I think that you know, there is both access and people are much more aware. And what it has encouraged is a debate within Black and brown communities about different health issues. So so that has had a kind of positive spin-off.
Other questions? Yes, Sigrid.
I don't want to monopolize, but I mean, I don't know whether you had a question, Zophia, but otherwise I would have a second one, sorry.
You can go ahead, I'll ask after.
Yeah, okay. I mean, the second one is I mean, where do you see the kind of critical discussions emerging? I mean, you mentioned Black Lives Matters that would address this structural racism that, I mean, I read it, it's not only just in the material structures, it is in the administrative rules, maybe hidden, not explicit, but somewhere in the second, third layer, but it's also very much in the thinking of people, no? In certain ways of classifying, of associating certain lifestyles or other things with color. So, I mean, where do you see in the US and in the UK, the most kind of forward pressing, you know, mobilizations and debates about this? I mean, I from outside perspective, I see it as a kind of a moment of openness. And I see, I mean, lots of voices being raised on this kind of issues, but I would be interested how you see it from the point of US. You're much closer and you're also, you know, familiar with these communities. So, I mean, and on what kind of issues? I mean, one thing is to discuss it at a general level, but would you think it's a kind of general awareness raising, or is it also that it needs kind of spear-pointed demands for specific, you know, issues, like, for example, access to health facilities and GP in a nearby area, and how is that to be achieved? Thank you.
I think we can all probably speak to this. Thank you for that question. You know, I think from all three of us, it's this recognition that it's not just based on health inequities, that it's these longstanding issues, and that this just happens to be the way that we're seeing it. And so specifically in the United States, it wasn't, you know, coincidental that after the murder of George Floyd, Breonna Taylor, and others, that there were these, you know, global protests. They happened in all 50 states and again across the world, to think about how state violence still relates to Black life, or at least extinguishing Black life. So in a way, the precarious kind of health outcomes have absolutely to do with state violence. They have absolutely to do with segregation. There are all these ways that conversations showing the relationship between all of these factors are vital. And it's only when we create these kind of silos that we're not able to have these really robust conversations. So certainly, yes, Black Lives Matter globally. I think that's not only a movement, but ways that folks in local communities have been able to think about how it's impacting their particular areas. But honestly, like, you know, so many have been talking about this. So that's why you can look at these various, for example, within academia, all of us have been talking about this, right? It's just we've been waiting for the next big thing that's going to just have this tremendous impact. So I really kind of want us to think more meaningfully about how this is a continuation. This is not new. It doesn't just have to do, like I said, with a vaccine rollout. We still have to think about labor. We still have to think about, again, the ways that people aren't actually able to live. And we don't have an investment in people living, certain people living. And I think in a lot of ways, even kind of the phrase Black Lives Matter, it doesn't go far enough, right? So it's kind of like it's the baseline, like the life matters, but then it's like, how do we live? How do we produce conditions to make sure we care enough? So even like I think this uptick in conversations about prison abolition are very much related to these health inequities as well. We're seeing the ways that prison populations are literally, they're being killed by having to maintain these small spaces, and this effectively are infecting each other because they won't release them. In California, you know, prisoners become firefighters, but we won't release them in order for them to be safe, despite the fact that we know that the transmission rate is so high. All of these factors matter, and I think the conversations that have been occurring in various kind of sectors still relate to COVID. It's just like these nodes that are connected to it.
Dr. Douglas, you want to jump in? I spoke second last time. I don't know. Happy to let you go first if you'd like.
Okay then. Well, I'm kind of thinking about it. It's interesting because I think here in the UK, at last we've started some conversations about the impact of racism on health. I mean, I myself have been working in this area for 30 years, and I had to look back at you know, some of the things I wrote 30 years ago to say, have I not been talking about racism and health? But it is good that at last people are actually starting to link health to other aspects of people's lives. And again, here in the UK, you know, we all know about George Floyd and about the policeman who has been imprisoned for his murder. But how many people know that just this week, you know, a policeman has been imprisoned for murdering a Black man here, and it took 5 years for this to actually go through the courts? I think there's something in the UK where there's a kind of dampening down of, you know, of the kind of inequalities, and I think that we need to start to address that much more. But having said that, the recent report, I call it the SAW report, I can't remember what its full title is, that actually said there was no systemic racism here in the UK, was challenged by so many people who are working in health. You know, people in the report, like Michael Marmot, who's done a lot of research on health inequalities, said that he was misquoted. So that I think the conversation is, you know, certainly kind of ongoing, and I don't think that we can actually move away now from looking at health inequalities in Black communities.
So I think that this is, I'm going to put my normal hat on, which is kind of the relationships between infectious disease, logics of colonialism, and discourses of racism and health. And I think, you know, I think this is a really profound opportunity, not just for kind of a global, not just for Black Lives Matter, but actually for kind of a global Pan-African, but also broadly anti-colonial moment to recognize the relationships between disease response, whose knowledge matters in the framework of responding to infectious disease, and a moment for instance, Black Americans to come together with Liberians, Guineans, and Sierra Leoneans, because the fact of the matter is, both of us have experienced epidemics that have required community engagements with a little response from the state in the early periods in order to figure out modes of survival. More broadly, and if you think about this historically, the first racially segregated township in South Africa before apartheid emerged out of the desires of the British-controlled Cape Colony to segregate for plague. countries in West Africa or colonies in West Africa were segregated based on threat of malaria between European populations and indigenous populations. The city of Kampala and Nairobi were both similarly designed in these ways out of infectious disease, racist infectious disease logics in response. So there is a long legacy and a long history of this. In the United States, tuberculosis was reasons for racial segregation in cities like Baltimore and a host of others. In San Francisco, anxieties and racist fervor around the spread of bubonic plague amongst Chinese populations was considered justification for racially segregated quarantines and the burning down of much of a part of the city. These are long legacies that are complex and also are a moment, and I think a space that we can galvanize real organizing for community-led health issue or community-led health work globally, potentially. This is me with my with a very optimistic and organizing mode, but I think I think this is an interesting moment to consider those potentialities.
Thank you so much. I now see John's hand is up. So John will ask a question.
Yeah, thank you. And I just wanted to say thank you to Zophia and others for organizing this really insightful panel. And I just want to thank all the panelists as well. I did kind of come in late, but I just wanted to ask a question about, and I think this picks up on some of the conversation that's been happening, but I wanted to ask a question about the intersection of progressive mobilization and local politics. And I just wanted to know, and this is Giannu, by the way, my son, he's really active today. So, and I just wanted to ask you about if you guys could just kind of speak to how, if you are seeing people who are affiliated with local movements kind of move into local politics. It's something that I've seen myself here in St. Louis and in other places. It seems like it's been happening more and more. Legislatures are and local governing bodies are becoming more racially diverse as I see them. So I guess there's a question as to, is this something that you're seeing? And then also the larger question, does this, what impact does this have as far as you see it? How should we be thinking about this? I know that here in St. Louis, we've just gotten a new mayor who is really advocating for defunding the police, reallocating a lot of the resources that were earmarked for law enforcement into public health and into COVID relief and things like that. So it does seem to have some bearing on sort of this conversation and about particularly the health disparities that affect communities of color. But I'm just curious to know like what you guys are seeing and what you guys sort of think about this kind of thing, or what you all and what you folks think about this. Thank you.
I've always been going first. I'll go last.
Okay, I'll go first. Only because I think our kind of political system here in the UK is perhaps not as well organized in terms of involving local communities. So what I can see is that there are a number of Black organizations that are actually lobbying for a whole range of issues, including COVID, including a kind of response to Windrush. But how that translates into political representation, I'm not sure, because we have so few Black and brown politicians here in the UK. And sadly, some of our Black and brown politicians are with the Conservative Party and are actually kind of pushing forward. So the report I referred to, the Sewell report, has come out of the Conservative Party, and it is being kind of mobilized by Black politicians from the Conservative Party. And I think, well, I personally think that is a real problem for us, because we're not going to see radical change.
Right. That's me. Sorry. um, I mean, I think the area that I've gotten more involved with, and this is going to be fairly anecdotal, has been attempting to reimagine the public health system in the United States, which is largely I mean, I think in terms of our interpersonal relationship, it is largely absent from all of our lives. I think there's a ersatz space in which public health operates, but until there's a crisis, you blame public health, but when there's no crisis, you don't really see anybody. And I think the example I gave of Alabama, like if Walmart is your primary care provider, your pharmacy, and your and your food source, where you don't see the state in these actions, you don't see public health in these relationships. So we need to figure out ways of making public health community health again. And I think that in the absence of the funding for the public health system in the United States, I've been really energized by colleagues and comrades that I've met who are community health workers, promotores, and a host of other folks who are doing on the ground work that has saved thousands of lives in the United States, because they're going around knocking on doors, making sure people have food, making sure people have the resources they need to protect themselves in this pandemic. So I would love to see a mobilization. What I am seeing and what I'd love to see more of is this community health mobilization, such that it becomes a huge aspect of maybe not a structured public health system, but rather the foundation upon which we think about health engagement in this country.
Thanks so much for that question. I think the Bay Area in particular has been really active in that sense, so probably like St. Louis. So with the Moms for Housing movement that occurred here since the end of 2019, Carol Fife, one of the leaders and organizers for Moms for Housing, became a city council member just this past fall. And so she's been working in particular, it was an upset in terms of her getting that particular seat. And she's radical, like she is truly progressive. And so I think as it relates to Oakland's leadership, we're starting to see, or probably have been seeing, a continuation of class dynamics being played out. So we can't presume that if a Black person is in power, that they're necessarily going to look out for the needs of the Black poor and working class. And we're seeing that in San Francisco in particular. San Francisco has a Black mayor, but London Breed, in looking at her record, isn't as progressive as I think a lot of people might have wanted to, or at least hoped, right? So it's really, we're starting to see the ways that, as we know, Black isn't a monolith. Black isn't one thing. You have to recognize how people's politics get played out and who they're caring about. And so in terms of thinking about health, it's connecting not only, with housing in particular, as I said, with Oakland. So we're thinking about housing, we're thinking about policing. We saw that the Oakland public school system was able to get the Oakland police out of the school system most recently. But then also thinking about environmental concerns. So those populations specifically in Oakland, West Oakland, where more Black people have lived and also have the highest rates of asthma. There are other, health outcomes that are impacted. So, if we're dealing with a disease that attacks the lungs, then for a population that's most vulnerable economically, but also in terms of health, there's yet another crisis that we're having to deal with. Or, groundwater being polluted in a West Oakland high school where they had to evacuate. And this is before the shelter in place occurred last year. So these are ongoing issues that I think some people who have been activists in the area are starting to really turn their focus and not necessarily, and really kind of attack capitalism in the ways that people are still trying to benefit and profit from the distribution of certain resources, rather than having communities be able to kind of create networks, mutual aid, et cetera, to make sure that their communities are healthy. I think it's happening. And some others, really smart people, Keeanga Taylor and others, have written about Black political structures and the ways that the Black middle class haven't necessarily turned their eye towards the Black, poor, and working class. And we're seeing this getting played out even as COVID still ravages these communities. But that's a great question, and something I think that I'm hopeful, but I'm just not certain as long as we just see it along the lines of race.
Thank you. So we just have 4 more minutes left in this session, and I see 2 hands up. So I guess what we can do is have both Jasmine and Nancy ask their questions, and then the presenters can take what they want, and then we'll close. So Jasmine, do you want to ask first?
Yes, thank you. I'll keep it short. Thank you for these very insightful presentations. So Dr. Dirkle has previously mentioned the involvement of NGOs, so I couldn't help but wonder, in how far did you sort of notice a change in governments to include civil society organizations more officially? Or yeah, in how far do you think this is being supported by governance, by local leaders? And how far do you think it can be effective to further people's access to healthcare? Thank you.
And I wanted to raise an issue. I'm not sure, speaking from the US, how general this is in Europe and other parts of the world, but the effects on people of all kinds, but certainly non-whites and Blacks in particular, and Hispanic, Latinx people in the US as well, has been substantially affected by the politicization of the pandemic in the United States. Unfortunately, we had a president whose personal wealth was tied to the kinds of jobs that would be most affected by shutting down to deal with the pandemic: entertainment and not casinos, but hotels and golf courses and so on. And supported by a party that has made it explicit that they are hysterical about having health of any kind being addressed by the government. They've been fighting for years to keep funding from being provided for healthcare, and they did not want this pandemic to be a bridge to further expectation that the government somehow should address health issues. And right-wing billionaires have made it clear that they don't think there should be any funding for public health because they don't want the government having that kind of power. So I don't know the extent to which those kinds of things are also evident in Europe and other parts of the world. And then one other thing that I wanted to address in this 1 minute is that the US initially did not have a plentiful array of vaccines. And it was very clear that there was lots of ways that well-to-do people and white people in particular got first in line to get these vaccines. But the nature of the vaccines themselves were also a part of this complexity because they had to be kept in sub-freezing temperatures. They couldn't be easily moved around. As they learned more about it, they found that there was less restriction than they initially thought, but it still is very difficult to administer these vaccines. And then we had the tragedy of the AstraZeneca vaccine in the UK, and I guess the Netherlands, and then the Johnson & Johnson vaccine in the United States, having questions raised about clotting problems that was being created. And then this huge disaster of having a subcontractor who was generating the Johnson & Johnson vaccine in the United States not use the right protocols and having destroyed millions of doses. So the opportunity for the one-shot vaccine, which would have been available to poorer communities because it would have been easier logistically, became tied up with this politicization of the response to the pandemic, and then also concerns about that particular type of vaccine potentially having more serious downsides than the mRNA vaccines that were available but very difficult to deal with logistically.
Shall I answer the question quickly about community organisations and in the UK? Because we have a really good example. Two young Black women actually formed an organisation called 5 Times More, based on the maternal mortality rates amongst Black women. And the two women actually organised getting a petition asking so that if you set up a petition, after a certain number of signatures, you can actually have this debated in Parliament. So they set up a petition, they got 187,000 signatures. And so it was this year in April, the UK government actually debated the issue of Black women and maternal mortality. So that kind of demonstrates how community organisations can actually have an impact on politics. And, you know, what they've done is enabled much more discussion amongst policymakers, politicians, and like health professionals about the alarming statistics about Black women and maternal mortality.
Go ahead. My headset cut out for a second during the question, so if you could repeat a little bit of the question, I'd appreciate it.
Nancy's question or the
Yasmin's question, I think. Sorry. Yeah, sorry, I'm sorry.
I was just wondering about in how far there is governance structures to enable NGO or civil society involvement in people's access to healthcare. Like from the talks that you have all given, it seems like especially civil society or individuals have been crucial in the access to healthcare for Black and Latinx communities in the US as well as the UK. So my question was, in how far are governments or public institutions ready to accept non-state third sector actors as being involved in governance?
And sorry, we only have like about 1 minute left. So if we have a really quick response.
I can respond really quickly. I'm sorry about the sound issue. I mean, I think it's across the US, it's civil society organizations, community health organizations have been absolutely critical, but I think the relationships are patchwork across the country, so they're not as networked. You know, I think the United States, as Nancy mentioned, has a particular history of kind of being very hands-off when it comes to healthcare provision. So, you know, I think the idea is in some ways for private entities, and I mean more corporate entities, to fill the vacuum that the government is left in healthcare, though, you know, what we're actually saying is where it really matters. I think there are these community health organizations, and I think in general, you know, more funding and support should be going to them.
I'll just say really quickly, I know we have no time, just in relationship to the vestiges of the Trump administration, thinking about the debates over critical race theory. And so taking away language to talk about the discrepancies, but also politicizing health is very much related to what we can say about structural racism and the impact on different communities. So all of these things are related, and specifically as it's being played out in the United States, though so many are trying to make it seem as though they're independent or ways to marginalize or oppress majority populations. So again, all of this seems to be related and having this tremendous impact on the communities who need, you know, the most assistance and access.
Thank you so much. And I'll just add one extra piece to this as well, is that I think, you know, the Trump administration might be seen as a unique sort of situation, but when we look at the logics of neoliberalism, right, and imperialism, we actually see this as a global problem. So now we're seeing that countries that actually did really well for the entire year of the pandemic are now suffering because they cannot get the vaccine, because countries in the metropole, you know, the US and Europe, have been hoarding vaccines. And so now we're seeing waves coming in in other countries. So, and this is under the Biden administration. So it's a continuation of these policies that harm people of color around the world and in the US. But thank you so much to our panelists for these phenomenal presentations. And we really look forward to the other feature panels. Please do look at the program and attend as much as you can. Thank you so much, Dr. Summers, Dr. White, Dr. Douglas. And just before we leave, SASE would also like to thank this year's virtual organizers, the KHK Center for Global Cooperation, in collaboration with the IAQ and the DIFIS. And so you can find out more about these institutions by looking at the logo on the homepage of the conference. Thank you all, and I look forward to seeing you at the other sessions.
Thank you so much. Thank you everyone for coming.
Thank you so much. Thank
Bye.
you. Thanks for your questions.
Thank you.